Testosterone isn't just for men. In fact, it might be the missing piece in your energy, libido, and metabolism. Welcome to Hump Day Hormones. I am Dr. Jill Jennings, a board-certified OBGYN and Menopause Society certified practitioner.
And I'm Courtney Spann, a nurse practitioner. We work at the Women's Clinic in Little Rock, Arkansas, on the campus of Baptist Health. We are here to talk about all things female hormone related, from puberty to menopause and everything in between. We are here to inform you from a medical point of view about the latest scientific evidence in the world of hormones.
You can find us on social media, Facebook and Instagram, as well as YouTube as Hump Day Hormones. And you can email us your questions or topics for the show at humpdayhormones@gmail.com. We just wanted to have a quick little disclaimer that everything we talk about here is for informational and supportive purposes only, and this is not medical advice, as we are not your provider. Your body is unique, and so be sure to chat with your healthcare provider before making any changes to your healthcare routine. Welcome back to Hump Day Hormones. This is season 2, episode 69. We are going to do like a testosterone series here. So we wrote this one big long episode about testosterone, and then I kind of realized that if we honestly sat here and recorded the whole thing, it'd be like 2 hours long, and you probably just don't care about listening to us for 2 hours. So we're going to divide it up into kind of like 3 or 4 episodes. But the first one is just going to be today. We're just going to talk about like, what is the deal with testosterone in females? What do we know about it? Why do we think women need it? And what is it helpful for? And then we're going to do kind of a second one that's going to be about the proven safety benefits of testosterone that we know about, and talk about specifically like testosterone for breast cancer, testosterone for heart disease, and kind of get into really that safety piece of it. And then we're going to do kind of the third part, which is like, if it works so well, then why the heck won't the FDA approve this? And why don't we have female dose testosterone that we can prescribe and get insurance coverage in the United States for? So that's going to be kind of our 3-part series. But today we're just going to talk about kind of what is the deal with female testosterone? Why is it so misunderstood, underprescribed? And honestly, like just underappreciated as a female hormone. I feel like there's massive appreciation in the male space. I mean, there's low T clinics all over the place for men. But we just a lot of times don't even think of testosterone as a female hormone, much less as something that we would actively take and replace in a female. So,
well, and I think that's the big thing is like we have just kind of categorized these hormones as like estrogen being a female hormone, testosterone being a male hormone. And we've got to know and remember that like both people make both hormones, just to like different degrees of it. And so, I mean, women make testosterone from their ovaries and from their adrenal glands and really good levels. And if you kind of break it down, which we'll talk about this in a second, like we actually make more testosterone than we do estrogen. I feel like that blows everybody's mind.
I know. Just drop that bomb on you right here at the beginning.
Yeah.
I think most people don't have a good appreciation for that at all. So we just want to break it down. So yeah, like Courtney was saying, our ovaries make testosterone, which obviously the problem there is that as we go through life, really, testosterone decline doesn't even wait until perimenopause really to start. But there in females is a decline, in males too, but their decline happens much later, kind of late 50s, early 60s. Our decline happens sort of early 30s, late 20s kind of thing. So We do make it from the ovaries, but that part declines with age. We also make it from the adrenal glands. That part also declines with age.
Yeah.
And then we make it, one other place is just from peripheral tissues. You can convert these precursor hormones such as DHEA and androstenedione that come, mostly from our adrenal glands. Those can get converted in the fat, in the skin, in the muscle, liver, breast tissue, hair follicles. Those can get converted to estrogen. So there is some peripheral conversion. So it's not like if your adrenals made none and your ovaries made none, you would still have maybe a tiny bit just from this peripheral conversion situation. But I think, what most people fail to recognize is that we don't get to estrogen in the hormone cascade pathway until you pass testosterone. So actually our estrogen production has to get through testosterone to get there. So it all starts as like a cholesterol precursor. And then we go down these pathways, but the pathway to get right before estrogen is testosterone. So, that's right. Like I'll say it again, you don't get to estrogen without testosterone, except for that tiny bit of peripheral conversion from estrone in our fat. But even in the ovary, testosterone comes first in the production pathway. And so in premenopausal women, the ovary makes estradiol in two different cells. The theca cells in our ovary make androgens, so androstenedione and testosterone. And then our granulosa cells are responsible for aromatizing those into estrogens. And so, we think a lot of like what may go on in the PCOS population or these girls that have over testosterone production is they're not as good at aromatizing those into estrogens before they leave the ovary. Because technically we think of what's coming out of our ovary as estrogen. But if you leave too soon, you may actually come out as testosterone. So, I think that is so underappreciated. And honestly, there's probably lots of OBGYNs who would be like, that's not true. Like our ovaries don't, make testosterone that then converts into estrogen. It's like, I know that's not how we were taught that, but actually if you look at the science behind it, that's exactly how that happens. So, and then in menopause, our peripheral tissues convert androstenedione to estrone, and then we get some conversion in the peripheral fat, usually from estrone to estradiol. So that's how menopausal women still have a little bit of estradiol. It's usually not a measurable amount. When we measure it in a lab, it's usually less than 25 or less than 10, that kind of thing. But it may not be exactly zero because you're still getting peripheral conversion in the fat tissue. But yeah, and then that's going to be much more dominant than testosterone production at that point because you're really not producing much of anything out of the ovary anymore.
Right. And I think if you're looking at the numbers and what you see on the labs, it's really interesting because estradiol and testosterone are measured in different units. And so estradiol is measured in picograms per milliliter. Testosterone is measured in nanograms per deciliter, which is a bigger unit than the picograms. So, if you do a little conversion and some old school algebra, it kind of takes you back to line everything up to the same units. And if you do that, typically we have 5 times as much testosterone as we do estradiol. And so I think that's super interesting to think about too, is just because you see a number on a paper, I don't know, kind of take that with a grain of salt, but just know that those two things, estrogen and testosterone, they're not measured the same way. But if they were, our testosterone would actually be
higher,
300 or whatever, instead of what it may be typically showing.
I know. And I don't know, like, really where that came from. Like, I don't know who standardized, like, what units do we need to report certain things in. But yeah, it's really weird to me. And I remember when you could have told me this 10 years ago and I would have been like, you don't know what you're talking about. Girls do not have more testosterone than we do estrogen. Right. But when I really, took a deep dive into this hormone space and started really paying attention, because we just say numbers a lot. We say your testosterone is 39, your estrogen is 112, but nobody says your testosterone is 39 nanograms per deciliter and your estrogen is 112 picograms per milliliter. Like, no, we don't talk in those units. But when I started really looking at that, I'm like, okay, but if we talked about that testosterone in the same units, like, hang on a second, like that would be that you'd have much more, your testosterone would actually be higher than, and you kind of start diving into that and then realize that, like, yes, that has always been the truth. It's just really never been taught that way. But yeah, like if you equalized it, 100 picograms per milliliter of estrogen is like, would be saying that if that person had 50 nanograms per deciliter of testosterone, but you put it in picograms, it would be 500 picograms per milliliter. So, yeah, I mean, that's just wild to me. Yeah. So, that we weren't taught that. I know for sure still not being taught that. And just really in general, I think we're not taught about testosterone as part of the female reproductive cycle. Like I did an experiment when I was writing this podcast. I just went on Google and type in like female menstrual hormone pattern or, something like female menstrual cycle. And you'll get the classic graph that every single like nursing med student, was taught about the menstrual cycle, and that your FSH goes up and then your estradiol goes up and then you get this LH peak and then you ovulate and then your progesterone goes up. It's all these very rhythmic. And the first time you see it, you're like, what the crap kind of, LA highway system do we have going on here? This is just lines moving everywhere. It makes no sense to anybody. But what's interesting is that testosterone's not even on the graph. I mean, why don't we put that on there? If we did, it would sort of mirror what estrogen does in that it peaks right before ovulation and that kind of thing. But it does change throughout our cycle too, just as the stimulation of those ovarian cells change. But, I think it's interesting that it's like truly not even on the graph in the vast majority of cases.
And for so many women, it's like the first hormone that really starts to decline. Yes. Like it starts to go down like in our 30s. I mean, or even like early 30s, you'll start to see a decline in testosterone. And you can be very symptomatic from that or start to notice some symptoms like brain fog, fatigue, mood changes, decreased libido. And I feel like those symptoms are really easy just to be like blown off. Like, oh, you're just a busy working mom. You have 3 kids. You have a full-time job, blah, 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 whatever. But there may actually be some biology behind it and some actual declining hormone levels.
Yeah. And I feel like what's so infuriating about that is if you're a man, and granted, they're dealing with one hormone, right? But it's such a well-accepted practice to be your testosterone's low. Let's give you more of that. And then somehow in women, it has become so well, I can't do that because I'm going to grow a beard, or, I don't want to transition to a man, or there's all these reasons that people kind of are told or maybe gaslit into, well, you don't even want to go down that lane of things, which, we'll go through, none of that's true. But yeah, I think it is so interesting that the order of events and how we lose hormones is really the opposite of how we're taught. We're just taught about estrogen, estrogen, females, estrogen, boobs, periods, babies, that's it. And then like the order of how we lose them is like we start losing our testosterone first, then we stop ovulating appropriately and lose our progesterone. And then the very end of the road, when you're finally hot flashing and miserable enough that someone will finally take you seriously about menopause, was when all your estrogen was gone. So that's really the last hormone we lose, but the only one anyone seems on board with replacing. So
Right.
it's all kind of backwards, but, and I will, we will, the week that we drop this episode, put this graph out there because it is so interesting. So Dr. Erwin Goldstein, he has a clinic in San Diego, and he's like a big sexual medicine. He runs a sexual medicine fellowship out there. I mean, he's big in that space and has done tons and tons of research and to kind of get to the place. I think he was even part of like trying to get this testosterone patch approved back in early 2000s. I mean, he's been in the sexual medicine female testosterone space longer probably than anybody, knows more than anybody. He has this awesome graph that he came up with at one of his talks that he was doing, and it's talking about this women's testosterone is actually higher than our estrogen, and it shows the decline. And so I do want to post that on social media at some point this week, just so y'all can visually see, because the decline starts earlier than estrogen. And it's just when you map them out on a graph and put them in the same unit, it's wild to see how much higher our testosterone is than we're actually ever led to believe. So
yeah, it's super interesting for sure. And yeah, so I think talking about like, what do we know about testosterone, where we know it works, what data supports, and all of that kind of stuff. I mean, the number one thing is sex drive. And I think everybody is probably familiar with that, you know, for testosterone. And the International Society for the Study of Women's Sexual Health, which is ISWISH, recommends testosterone replacement for like the diagnosis of hypoactive sexual desire disorder. So that just really means that you have a low libido that is bothersome to you. And testosterone has shown to be super helpful in that space.
Yeah, I always tell patients like the claim to fame for testosterone is that it helps your sex drive. There are so many more benefits, and we'll go through those, but this the number one data backed use, or if you're taking your Menopause Society test, you just need to know that's the one reason you use testosterone. That, you know, that could be your answer. Yes. It's not the only thing it helps with, but it's what we have all the data on. And so there was a large systemic review, a meta-analysis of 8 trials. So this involved more than 5,900 women. This was published in JAMA. They found an increase in the number of satisfying sexual events. So that was more like 0.49 more. So half more per month than placebo. I don't really know how you have a half of a satisfying sexual event, but I guess that's better than none at all. If you had 0.49 more. I mean, I guess what they're saying is like if you used to have 3, now you have 4. You know what I'm saying? Like it wasn't maybe an entire like doubling, but it I guess if you used to have 3, then now you have 1.5, or you used to have 4, now you have 2.
Right.
That kind of thing.
Right.
And then the sexual desire, this was done by like e-diary that they kept. They noticed a 1.63 in mean difference. So that's, you know, obviously an increase. And then the sexual desire, this was like a validated scoring system that they would use, 0.27 improvement. So improvement all across the board. Yeah. It was like statistically significant, not placebo level changes. It's one of the most evidence supported treatments in sexual medicine. So I think if someone is out there telling you sex drive for women is all in your head, like watch more porn,
drink wine, go on a date,
whatever ridiculous things that women are told, and don't do testosterone, there's no benefit in that. Like that is incorrect to the level of 8 review trials and a big meta-analysis.
Well, and the fact that it was like published in JAMA, like, I mean, you want to talk about like where you get good articles from. I mean, that's it. So, yeah, I mean, I think that's so cool that all of that had really positive effects and benefits in not only like sexual events, but desire too. And, I think those are definitely two separate things. So I think that's cool that you see improvements there on both things.
Yeah. And I mean, Kelly Casperson is a leading person in talking about female sexual desire, but our desire is so much different than men's desire. We, have this reactive desire, like multiple things have to line up. It's not like we're just at baseline thinking about sex, right? And so we have to feel well supported and safe and be happy in our relationship. And all these things have to be going on. It's not just this, thing that automatically happens, And so I think she talks about this a lot. Like, of course, testosterone helps with our desire because it is doing all of these neurological things. And so this kind of gets into our next thing that we think testosterone helps with, our like mental function, motivation, our mood. So anything that's going to help with your mood and your motivation and energy levels, like if all of those things are better, then you probably have a better sex drive.
Right.
If you're tired all the time and you're grumpy and you're having hot flashes and you're not sleeping good and your husband's on your nerves, then you probably don't have a great sex drive. So I think it's impossible to ignore the neurological benefits because in women, sex drive is a neurological event.
Yes.
So to sit there and act like
that is literally all in your brain.
Yes.
All of those changes that are happening. And I mean, they've proven this, that testosterone affects the dopamine pathways, the motivation circuits, the cognitive processing speed. So, I mean, that just means all good things to your brain, that you're improving like mood and motivation and mental kind of clarity and function there.
Yeah. And I feel like this is one of those things where we don't have some big meta-analysis or some big trial that says, yes, I have better cognitive clarity when I use my testosterone. And I think there's a lot of like reasons why. And I mean, starting with testosterone is generic. Like no big pharma is going to dump a bunch of money into a study of a generic drug because they can't patent it and make all the money off of it. And so it's just one of those things like, who's going to do the study? Like who's going to fund the trial? These trials are expensive. And then some of this stuff is hard to measure. Like how do you measure? I felt a little bit more like myself again. I felt like I cared about getting up in the morning. I saw the world in color again. How do you do that on a study? And so, some of this stuff is just really hard to study, but we see it and hear it all the time that I just feel like myself again. And I think, it's hard to pinpoint exactly what that is. It's not a miracle drug, but I do think that, people do obviously get some of these benefits, even if we stay in physiologic range.
And that's like my favorite thing to hear. Like, yes, I don't want you to have hot flashes and like, I want you to be sleeping better. But when somebody says like, I feel like myself again, I'm like, yes, like my work has been done, and that you can't measure. So I mean, that would be really hard to like study, and you can't measure like brain fog, or when that lifts or starts to clear. So, I mean, so many barriers to like studies, that we would love to have. But, I
mean, really, I would say there are some side effects that we can get if you get too much testosterone as a female. Like you can be oily, you can have acne, you can stimulate chin hair growth, you could get hair loss, you could go down a laundry list and make it sound real scary, but if you keep in the physiologic range, we hardly ever see any of those side effects. So I feel like monitoring is really appropriate and safe and all that. But I also feel like nobody feels worse. Like nobody ever takes testosterone.
Yeah.
And I mean, yes, they may say I had to wash my hair. I couldn't go 3 days between hair washes. I was a little more oily, but no one's ever like, I felt terrible.
No,
I mean,
nobody.
Very occasionally we give people progesterone and they don't like it. It makes them too tired. And it does have that sedating type of effect. So there are some progesterone intolerant type people, but I don't feel like anybody's ever like, I hated testosterone.
Yeah. It's either like, minimal effect or positive. I mean, it really never like makes things worse.
And I do feel like that is part of the problem for why it has been overprescribed and sort of overpromised. I don't know, like maybe the appropriate way to say that, but I feel like just anybody and everybody, we've got this perimenopausal population who just doesn't feel good for one way or another. And like, okay, you need some testosterone. Everybody needs testosterone for everybody, and it will make everything better.
Yeah.
Well, I mean, partly, yeah, everybody's going to feel better if you give them a little testosterone. You may still have not gotten to the root of their problem. They may have big cortisol dysfunction going on. They may have a thyroid problem going on. They may have needed some estrogen that you're kind of giving them because their testosterone is going to convert to estrogen in their peripheral tissues. And so I feel like, just maybe go into like a med spa or go into just all these random places that can now prescribe testosterone, and just being given big megawatt doses of testosterone and kind of told it's going to solve everything is a little bit of a problem too. And I feel like they're taking advantage of the fact that people do feel better on testosterone, but you just may be masking all the other things that you didn't
that
look
could
for
be going on. And I'm telling you, it is easy to throw a big old fat testosterone pellet in somebody and jack up their levels. But I mean, if you do it in the like appropriate way and stay in physiologic, it's going to take a little bit more time, and just the patient kind of being consistent with like, a cream or injections or maybe not such a high pellet dose. I feel like I always kind of have to reinforce to patients, like, I know you want to feel better tomorrow, but you've got to give this a little time. And then once they get there, they're like, okay. Like, I'm glad I did it this way. And, I didn't jack a whole bunch of stuff up just to feel better next week temporarily. Right. So I think that is something to think about as well.
I know. And just being like in full disclosure, because we've done like whole episodes on estrogen brain benefits. And we are saying that we do know of some brain benefits. Like there's, all this emerging evidence for testosterone with energy and executive function and all this. We really do not have any data to say that we have dementia prevention. So this is more of like quality of life type stuff. Like in the estrogen space, if we started at the right time in the right candidates, all that kind of stuff, we truly have like dementia, Alzheimer's risk prevention type stuff. So just in full disclosure, we're not saying that about testosterone. I just want to be honest about what approvals we have and we don't. And so next on the list that I feel like is always the question, because we have these images of like bodybuilders and like big old muscled up dudes abusing testosterone. So I'm going to take testosterone and I'm going to become a bodybuilder. I don't want to be bulky is what women will tell me. I don't want to be bulky. And like, that's really not the kind of testosterone that we're talking about giving you. It's just bioidentical testosterone, like just what used to come out of your ovaries and your adrenals. We're not talking about dihydrotestosterone or, really this kind of stuff that was part of like doping scandals and bodybuilding and all of that.
Right.
And really, I mean, they have done these studies that we do get slightly improved body composition and muscle mass, but you're not going to bulk up. You're not going to build substantial muscle unless you're like going to the gym and lifting heavy weights. It may be easier to build muscle being on testosterone, but it's not like you can sit at home and inject or rub on your testosterone or whatever and just be sitting there building muscle. Like, that's not how
Right.
that works. You have to actively work to build the muscle.
Yes.
In the gym.
And I feel like I hear that a lot. And I feel like people that work out regularly and all of that would probably say, yeah, you're not going to just be able to use some testosterone and then get all those effects. Like, if you want to build some muscle, you're going to have to like work your ass off, you know, like if you are just putting all your eggs into like testosterone and letting that be your thing, like that ain't going to do it.
Yeah. I mean, you will have some slight improvement in your muscle mass, which the long-term payoff there is that our muscles are a big place where we use up sugar. And so we're going to help our insulin levels, like lower our insulin resistance, help our insulin sensitivity by having more muscle mass. And we do lose muscle mass as we get through perimenopause, and for sure menopause, we know we lose muscle mass, mostly because we're losing testosterone. So, I mean, again, we're just kind of replacing you to where you weren't a bodybuilder, just roid raged out when you were 25.
Right.
And so just because we take you to those testosterone levels doesn't all of a sudden mean you're going to be popping out muscles, but it may be easier to gain muscle, and you will have slightly improved muscle mass, which will help you burn through fat and help to increase your insulin sensitivity. So that's like, I don't know, the $1 million question in this midlife space is like, but is it going to make me lose weight? So that's what we all want to know, is why we're gaining and why can't we lose? Why are we doing the same things we used to and we're not losing? One of the big things that happens there is our insulin resistance problem. And so in a very roundabout way, testosterone does help with that, but it is probably not going to make you like lose weight, because we're improving your muscle mass and improving your insulin sensitivity, but we're probably not going to see like a number on a scale go down all that much, because what you lose in fat, you might kind of gain in muscle.
Yeah.
So I just don't, like, if you're expecting someone like to drop a number on a scale dramatically, testosterone, it's probably not like your go-to there. If we're trying to help with just like midlife muscle maintenance, which is so good for our bones and insulin resistance, then yes, there's improvements for sure with testosterone and those things. I mean, it can maybe make weight management a little easier, but it is not a weight loss drug. Yeah.
I think it's just got to be included, like, you know, in your toolkit, like we talked about your toolkit. It's just like, you know, hormones, exercise, eating healthy, getting good sleep, kind of all the things to use during this time. And I think, testosterone is just in there. It's not the only thing that you need, but it can be helpful.
And I think the same way we talk about it for libido, like you're in a better mood, you have more energy. Of course, you have better libido. Well, you have more energy, you're in a better mood. Maybe you want to work out more. You have more motivation, all that type of stuff. You don't feel like shit. So maybe you do want to go to the gym, and maybe that does help you lose weight. So there's kind of those secondary benefits to it too.
Yeah. I really I don't love when any patient feels like total shit, but I love when that's kind of our starting point. And they're like, I can't get off the couch to do anything. You know, I can barely even like function at work. And then as soon as I get home, I'm on the couch. It's so interesting to kind of start correcting their hormones, and then they're able to like function more, and then they're able to make better decisions about what they eat and how they move and exercise and what they do. So that is very rewarding to see that.
Yeah. And it's kind of been the opposite for so long, right? That same person, you know, might come in like, I just have no energy. I just want to get on the couch as soon as I get home. People are like, well, you just need to go to the gym. Like, well, why don't you help me feel better so I can do that?
Right. Yeah.
I agree with you, but why don't you help me do that? And so, I think this is a place where we see a lot of that stuff happen. And then the like gold shining star, other than like it helps your libido, which we've got those studies saying that, the other like gold shining star here is the vulva. So like it helps your libido, but let's talk about your sexual tissue health, like what you're going to do with that libido and this vulva and
Right.
vagina that you have to use with that libido. What testosterone does for those tissues is so awesome. And I don't feel like that we think about like having a testosterone receptor throughout our female genital tract, but that has been well studied and documented. We have testosterone receptors in the clitoris, the vestibule, which Dr. Goldstein talks about. The vestibule is like this very most concentrated place for testosterone receptors down in the vulvar area. And he talks about that you don't get to the vagina until you cross the vestibule. And so, you know, if that's going to be a big deal in thinking about pain with sex, like we have to get past the vestibule to even get into that vagina to have sex. So the vestibule is basically the entryway to the urethra and the vagina. And so chock full of testosterone receptors there. And then our bladder has testosterone receptors, and then obviously our vagina. And so, I mean, you know, just when you take away androgen signaling, so when our testosterone goes down, we have obviously the reduced arousal that's coming from like that neurological space of like even thinking about sex. But the tissue itself is different. It doesn't have the same nerve supply. It doesn't have the same blood supply. So we have diminished orgasm intensity. We have vulvar thinning and discomfort, which estrogen plays into that a little bit as well. And yeah, just that overall decreased sensitivity, urinary urgency and frequency in some women. Again, huge crossover with estrogen, and then recurrent symptoms that are not fully relieved by estrogen alone. So I think testosterone, I mean, by itself would be wonderful in the vulvar vaginal area, but especially with estrogen would be really good there. And I mean, I feel like we're so like shy to talk to women, or women are for sure. We live in the deep South here, but I mean, they're shy to bring it up. And it's kind of one of those like, well, maybe we just won't ask if they don't bring it up. I mean, I don't mind to talk about it, but probably their PCP is not going to say like, are you sexually active? I mean, just first of all, do you want to be sexually active? And then when you are sexually active, is that satisfying for you? Because that's the other component is like, maybe you don't have a good sex drive because it hurts every time you have sex, and nobody desires to do something that hurts. Or maybe you can't have an orgasm. You haven't had an orgasm in 10 years. Well, I mean, that's not really fun either.
Right.
So, I mean, nobody's going to, let me go back and get some more of that if it's not, you know, satisfying in the first place. So I think that this plays a lot into that. And we get a lot of women that say like, I don't really have a great sex desire, but like when we have sex, it's fine. But sometimes it just feels like nothing. Just feels like
the whole decreased sensation. And all
it feels like it has no nerve supply. Or some people will think that is like, I've just had, you know, 2 or 3 babies, and maybe that tissue just, you know, got damaged in that and just doesn't feel the same. Or they've made up, you know, all these reasons why, you know.
I have so many women will say like, you know, I guess that's just part of like getting older. I'm like, no. Like, let's investigate here. Like, are you already on vaginal estrogen? Okay. If you've already been on that and given that a good trial, let's add some testosterone to the mix and see if that doesn't, you know, help all of these symptoms, because we know it is going to improve like the tissue integrity and the blood flow and the nerve sensitivity. And so really once you kind of break the ice and get patients talking about it, you really will learn so much and figure out like where you can be helpful. You know, is it a tissue problem, like a tissue issue? I feel like that's what our pelvic health girl said. Is it that? Is it desire? Is it, you know, pain? Is it, and you can figure out like where you're going to be most helpful.
Yeah. And I feel like there's such like a complementary relationship. I mean, you all have heard us say before that kind of everybody, like all people, women should be on vaginal estrogen. Like if it's time for your wrinkle cream for your face, it's time for your vaginal estrogen. But really that's going to help with more of like our moisture, our mucosal thickness, that collagen layer, that elasticity. And then testosterone's more like the sensation, the blood flow, that connective tissue tone, the nerve responsiveness, and then erectile tissue function. I feel like no one ever wants to talk about that, like our clitoris is like our penis. It's like our erectile organ. So that's not weird. Guys talk about their penis and their erections all the time. Like, why can't we talk about that? So, but it's like we take a lot of, or urologists take a lot of care for, erections. I mean, they have whole, pathways and developed care plans for that. And it wouldn't be a big deal at all if you were a man and you couldn't get an erection to get an appointment with a urologist. But I don't think anybody ever makes an appointment for my clitoris doesn't feel the same as it used to.
Right.
And they probably just don't know that they could, and that there could be a solution for that, because we're just taught like, well, that's just part of aging.
Right.
But yeah, there are things we can do for that as well. So, I mean, I would say if you're listening, you don't have to like call and explain it all to the scheduler. I get that it's kind of embarrassing, but anybody who is dealing with a female genital urinary system, so a urologist, an OBGYN, I mean, if they can't talk about the anatomy that they take care of, that's a problem. So just get with somebody who will at least like hear you out about it. And this is, I mean, big proven benefits to using that. So I think libido and, vulvar vestibular health goes sort of hand in hand. Yeah. But I mean, that's where we get the gold star for testosterone and what it's really doing. And yes, it is going to give you energy and make you feel better and all of those things as well. But it is not testosterone for everyone, for everything.
Yeah.
All the time.
You definitely got to do your due diligence. I think it's just one of those things, like, just like kind of we always say, if you feel like something's off mentally, physically, sex doesn't feel the same, you don't feel the same, you're tired, you're, can't think because you're so cloudy, like, let's evaluate. Let's see if testosterone could be helpful. Let's make sure everything else is in a really optimal spot as well.
Yeah, and let's not be throwing testosterone on Hashimoto's or cortisol dysfunction or just straight up menopause and telling people that that's all they need. Let's dive in, check all the things. So
that's right.
Can you imagine if we kept on talking about all the other stuff we have to say about testosterone? Y'all would be so sick of us. So we are going to wrap this up this week. And then next week, we're going to go through the safety, like what we know about testosterone's safety, especially around, like, everyone's always interested in, like, well, what about breast cancer? And then in cardiovascular disease space. So we're going to go through that kind of stuff. And then after that, we're going to talk about why the FDA, is gatekeeping this stuff. So
that's just going to be a good rant session for us. So if y'all enjoyed our episode on ranting about the WHI, stay tuned.
I know I can get pretty heated about that, but there's like so much inequity, like in the male female space. But anyways, I'll save that for that one. If y'all don't want to hear it, then just don't listen. But I hope y'all have a great week. And I'll let Courtney do her little disclaimer.
Yeah. Well, I'm glad you have this one written down because I straight up I can't even think of what I normally say. But basically, our podcast is for educational purposes.
Education.
I mean, I'm done for today. This is for educational purposes only and does not constitute medical advice. Your body is unique. Talk to your healthcare provider before making any changes to your health routine.
Yes. And if they don't know about vulvas, find somebody who does. Okay. Have a great week. Bye-bye.